Hi, I'm Dr. Jared Nielsen here in Heber City, Utah. I'd like to talk to you today about the importance of children's health care. Specifically, we're talking about the ears and the importance of protecting the ears, and then what to do when a child experiences an ear infection. Whenever we look at the child's ears, especially in the newborn, the toddler, we really need to make sure that the child is responding to sound. A newborn infant will respond more quickly to sound even than before their eyes begin to track. And so simple things like snapping to just see if the head will turn toward the source of the sound is a quick way for parents to be able to reference, does my child hear? It's often missed because the child may not make audible sounds or simple cries that would be indicative of a hearing loss as the child matures or grows. The sounds that typically a baby would make of the oohs and ahs may still be made even to the child that can't hear well, and again the parent may miss, but then as developmental delays in speech become more apparent, that hearing may be where we're missing the ability to actually communicate. So as you see your newborn child or you look at the developing child, please just take a moment and make sure that they're responding equally with their head responding to the source of the sound. Now, if you suspect a child has an earache, often they'll tug at their ear, be fussy, and it's difficult at times to ascertain, is this really an earache or an ear infection? A simple test again is to just touch in front of the ear or just behind the ear very, very gently and just see if there's a withdrawal response or a fussiness associated with that. If there's pressure in that ear, the child will often respond adversely or directly to that. Because there's often a fever linked to ear infections or earaches, the child may then have that irritation, but commonly may be misconstrued because of the teething that is often associated with that timing. So again, evaluate if the teeth are trying to erupt, and then if you can determine again, is this more ear versus sensitivity on the gums. That can give us a good window into which direction do we need to go. When you look at a child who has an earache or an ear infection that's actually been diagnosed, we can take a moment and look inside the ear with an otoscope, and that's a clinical responsibility that we have. When looking in the ear, for those who are clinicians or who even parents who've had maybe some experience looking in the ear, when you look in the ear, you always hold the scope and look into the ear from a direction as if the canal would come at an angle toward the opposite jaw. So you're actually looking forward and slightly downward to determine that angle. When you actually look inside of the ear, you'll see the eardrum. And if we actually were looking at the eardrum from, say, the right side, actually me mirroring you, let's say the left side now, so your left, as you look into that left side, what you should see is that the ear itself will have a presentation where the membrane or the tympanic membrane should have kind of a grayish color to it, and right in the center will be a little ossicle or ear bone, and you'll see just this little raised bump there. There should be what we call a cone of light that's actually a reflection. So when the light shines into the ear, there will actually be a cone of light that's directed forward in the ear. In other words, you'll see what looks like a little triangle or a cone that points forward in that canal. Gives you a quick reference, but as you look into that ear, you should see the cone of light. Even when you're with the pediatrician, ask him, did you see the cone of light? Because if he can't see that cone of light, if there's pressure behind the eardrum, it'll actually push the eardrum forward, and you won't see that clearly demarcated light reflection that indicates pressure behind the eardrum. Also, when you look into the ear canal, you'll see redness and irritation that can also be noted as otitis media or the middle ear, or external otitis externa, that where you actually see this inflammation outside of the ear, more commonly associated with the swimmer's ear. When the pressure builds up behind the ear, also asking then, do you see bubbles behind that tympanic membrane, which is indicative of fluid in the ear. Commonly, though, what we just see is that the pressure is built up in there and it's not able to equalize. The anatomy of the ear itself, you have the ear, the external ear, then you have the ear canal, then you have the tympanic membrane. Inside or behind that tympanic membrane are three small bones that actually will then oscillate based on concussion of waves that hit the tympanic membrane and then give a reflex to the internal ear that gives us a sense of hearing. Also associated with that inner ear is the ear canals that have to do with our sense of equilibrium or balance. It's a righting reflex. So if you notice a child that has a severe ear infection, they may even be tipping or feel off balance. That type of inner ear congestion then is really linked as we go beyond that canal to what we call the eustachian tube. Now the eustachian tube really is an equalizing pressure mechanism that actually allows an open channel of communication for drainage to occur from the back of the ear into the back of the throat. So as you look in the back of the throat, you'll see what we call the pharynx or the uvula hanging down, and then behind that are the pharyngeal arches, and referenced behind that are the tonsils. If you open your child's mouth and have them say ah, the tonsils should be hidden behind the palatal arch or pharyngeal arch. We grade the tonsils if they start to kind of peek out behind that arch. So here's the arch. We start to grade it as a 1, a 2, a 3, or a 4, just breaking that canal up into 4 regions. And if it gets more and more swollen, then once we get to a 4, the tonsils will almost kiss, or in other words, touch to where it feels like it's blocking the airway and also then the ability to swallow. What's very interesting is, again, as you view that tympanic membrane from the observation of just looking into the canal, if you don't see the cone of light, then the eustachian tube is likely blocked. So either the retropharyngeal tonsils, those tonsils that behind, may also have tonsillar tissue that are adjacent to that. They'll actually block off or squeeze down that retropharyngeal space where the eustachian tube comes in. This will actually give that sound that some people have noted as almost like a clicking sound when you swallow or try to open your mouth, and you'll hear a little click, click sound as those tonsil tissues and that retropharyngeal space is actually opened. It will actually make almost a kissing or a clicking sound. When you see that type of or observe that presentation, that eustachian tube will actually fill up with a waxy type of a material, almost like a blockage that we'd consider either not truly wax but more of a mucus type of a blockage. Some researchers and some pediatricians or clinicians will refer to that as a glue ear, meaning that wax or that mucus will start to create a plug in the eustachian tube, and that will back up and now create pressure inside the ear that doesn't allow it to balance. So this is the little child that screams when the airplane is landing. You hear that little child in the back of the plane that's just screaming in pain, and the mother can't console it. Child's in tremendous amount of pain because the eustachian tube that we could just simply chew or clear our ears with as if we were going deeper in a swimming pool. You can clear your ears because those eustachian tubes are patent or open. When that blocks off or that gets stuck together because it's kissing so tightly, or there's actually a glue ear, then we see that that child's in a lot of distress or discomfort. The tonsils are actually a manifestation of the entire system. So a lot of people think, well, I just have tonsils here in the back of my throat, or I have adenoids in my sinuses. The reality is our whole digestive system is lined with these lymphatic tonsils, if you will. And the tonsils here in the back of the throat are actually a reflection of what's happening in the body. Most children that have food sensitivities will actually develop glue ear. And the most common thing that we see as an irritant for that is when the young child is begun too soon on dairy, particularly cow's milk. What will happen is the GI system will develop an irritation or antibodies against that, which causes inflammation in the lymphatic tissue throughout the GI system, but then it will manifest as inflammation in the back of the throat. So you'll see the child has a lot of phlegm, and that phlegm then can also build up, if you will, or that mucus will actually build up into that eustachian tube, causing then the glue ear. So one of the first recommendations when you see a child is in immediate distress associated with that blockage, we want to get them off of dairy for a minimum of 2 weeks to allow that tube to open up again, even if they don't have a true earache, but they can't quite open up those ear canals or get that balancing system righted because of the pressure. The next thing that we look at is when you are aware that there is a fever with an earache. Most commonly, ear infections are associated with a virus, not a bacterium. And the nice thing to differentiate that is, again, the fever, and the treatment then is not the antibiotic. The pediatricians now have acknowledged that the antibiotic use for ear infections has been way overprescribed in years past, and consequently will lead to other consequential infections. There are a couple of homeopathics that are very, very effective at upregulating the immune system and targeting viruses that commonly afflict the ears and will cause that fever and the red inflammation associated with the ear infections. Many times, pediatricians still will offer antibiotics more as a palliative effect because it quickly does reduce the inflammation, allow the child to begin to recover because they feel a relief of the symptoms, they can begin to eat again. Challenge again, though, is when we introduce the antibiotic too soon in the child's life, we actually create an antibiotic-resistant strep or staph infection. And this is where most adults will actually say, yes, I did have a lot of antibiotic therapy. And when you look in the adult or the teen child, you'll see large tonsils that actually have what look like craters of the moon presentation, and they'll actually develop little white stones. We call them tonsilliths. They smell horrific because that's actually an old staph infection that's antibiotic resistant, and it's actually pushed deeper into the system. The body uses those tonsils as a means to push that out. If that's a case that you're dealing with, there's a simple supplement that we use from Standard Process called Congaplex. And Congaplex has a great benefit in the adult who's had this history of chronic ear infections to eliminate that type of an infection. When we look at staph infections that are old and antibiotic resistant, their number one pal becomes the strep infections. And so when you look at the child that gets this recurrent streptococcal infection or strep throat, it's interesting because typically they'll have been precluded by some type of an ear infection that's been mistreated with the antibiotic prematurely. Now we have an antibiotic-resistant staph, and its companion becomes the strep infection, and now they're on this cycle of an every 3 to 6 months antibiotic through their toddler and into their young pediatric life up to age 8. Then commonly what ends up happening is the tonsils are removed because of the kissing tonsil presentation and the recurrent strep throat. The challenge in that is now just because we've eliminated the tonsil doesn't mean we've eliminated the infection, and so the adult may continue to manifest a myriad of health concerns. And the biggest thing that I see consistently is when we've had tonsils adenoids removed, we develop lower and upper GI distress, commonly food sensitivities, and this is where we start to see more consistently again the dairy sensitivities, the gluten intolerances or grain intolerances, and then the other intolerances that lead to leaky gut. So as you're looking at your child, think proactively, what are the things that we're feeding them in order to assist their well-being into life and into adulthood, and what are some things that we could do to actively engage their body in healing rather than trying to just take care of in the moment their immediate distress. Always a child should be alleviated of their pain. That's one of our greatest responsibilities as parents. We want our children to be comfortable. Tylenols, according to the pediatricians now and acknowledged by the pediatricians, and acetaminophen as the Tylenol chemical formula, impairs liver function. So we should remove Tylenol from our home first aid kits. Ibuprofen, if you need, is a better choice to be able to treat that fever if you need, or to reduce the pain or distress that the child's in. There's also a drop that you can use, echinacea hydrastis, to be able to reduce fever, and that really is effective at helping to monitor or regulate fevers. When we look again for the child who's in distress, we want to check their temperature, and we want to make sure that their temperature is within an appropriate range. A simple temporal thermometer, excellent to be able to quickly evaluate child's temperature. Keeping your child's temperature, remember, below 104 is really a healthy temperature, and a lot of people are surprised at that. Again, 104 degrees is safe for the child. A sustained temperature above 106 for greater than 4 hours is really a concern, but up to 104 is safe. A lot of patients or parents will say, I'm not comfortable with that, so using even a temperature marker of 102 to 103 drops that range back to a safe target. And when you look at that, the baby's temperature at 102, the baby's not in distress or in any distress or potential neurologic injury. So in summary, let's talk again. Parents, when you're looking at your child, make sure that your child is able to hear, responds to the source of the sound. If your child is actually in distress and you're not certain, because again, young children who are reaching the teething age or teething stage, just check their gums versus gently checking in front of or behind the ear to evaluate if there's a withdrawal response because of pain that may be there. When looking inside the ear, ask the pediatrician, did they see the cone of light, or is there so much pressure that that cone of light now is flattened and you don't see it well demarcated in the ear, or if there's actually fluid behind the tympanic membrane or eardrum itself. Remember that eustachian tube that comes to balance or allow pressures to be regulated in the back of the throat to the ear canal itself is called the eustachian tube, and that eustachian tube can often be blocked by inflammation associated with a virus, can chronically be blocked by a food sensitivity, and most commonly find that to be dairy in the young child. Eggs are common with that also, and in developmental states there may be some other things that could develop some food sensitivities, but then we'd be looking more for the eczemas or the vomiting. So again, when we're looking at the eustachian tube and a condition called glue ear, we actually are looking at a more common allergen associated with dairy. So I recommend 2 weeks off of that dairy for the child to be able to recover. If they have a true sensitivity, maybe longer. For those parents who even in themselves know that in the past they've had a long-standing infection, we recommend Congaplex for the adult, and this one is just a swallowable capsule versus in the young child who may have had the history of ear infections but still can't swallow the whole capsule. The chewable Congaplex is potentially a means of helping to eradicate the antibiotic resistant staph infection with its co-infection of strep. We use those together again for approximately 90 days. Now, as you consider again, is my child in distress? Remember, more often the ear infections are caused by virus, not by antibiotic. Fever is the best means of allowing that body to actually eliminate the viral infection. A safe target range, 102 to 103. 104 truly is safe, but we'll want to keep it in that target range, and if you want to set an upper limit of that goal, once you've checked their temperature and you monitor that's staying in that 102, 103 range if you feel safe there. 104 again safe. 106 that's kept under at 106 under a duration of 4 hours is still a safe range. I'm Dr. Nielsen. Thanks for taking the time to listen to this and share this information with you and your family and your friends. Have a great day.